Hello, all. Welcome. Glad you're here. First, I'd like to just introduce the GSU Prevention Research Center, and then I will pass the ball to our presenter today. So for those of you who might be new to us, Prevention Research Centers are a network of CDC-funded academic research facilities in the U.S. that study how people and their communities can avoid or counter the risks for chronic illnesses. Our Prevention Research Center at GSU, that's headquartered on the Clarkston campus at Perimeter College, works with community organizations, state and local governments, residents, and other partners in Clarkston to develop, implement, and evaluate culturally and linguistically responsive interventions to address disparities and determinants of health for migrants and refugees, and then to disseminate that work at the community, state, and national level. I'm pleased to welcome our guest for today, Dr. Megha Shah. Dr. Shah has a long CV that I won't go into great detail on, but in sum, she is a family physician. She is currently an assistant professor at Emory University in the Department of Family and Preventive Medicine. Prior to joining the faculty at Emory, she was a Robert Wood Johnson clinical scholar at the University of Michigan, and she completed her undergraduate studies in political science and health policy at Duke and went on to attain her medical degree at the University of South Alabama College of Medicine, and then completed her family medicine residency at Duke with a certificate in clinical health leadership. She practices clinically at the Emory Family Medicine practice in Dunwoody, is involved in a lot of education and training related activities for residents, and a focus on developing community partnered research. And her focus for her research is on community partnered approaches to chronic disease management, specifically novel strategies for primary care, diabetes prevention, and self-management in under-resourced communities. So please welcome me, please assist me in welcoming Dr. Shah today. Thank you so much. We're so glad you're here, and I'm going to stop sharing so that you can also share your slides. Thank you, Dr. Shah.
Thank you. Thank you so much, Ashley. Thank you for the introduction, and thank you for the invitation to come and share some of the work that me and my team have been doing. Can you guys see the presenter mode? Okay, fantastic. Again, thank you so much. And I just want to say that I am presenting on behalf of a team of researchers, and I have their listed names on the last slide, so I cannot take credit for all the work here. But I think as I heard the introduction to the Prevention Research Center, I kept thinking, oh, this will hopefully align well with the mission of the PRC. And so I'm really looking forward to sharing some of our work, but also to have hopefully time for a robust discussion and answer questions at the end of my talk today. Okay, let's see if I can navigate this. So I don't have any disclosures, just a brief sort of roadmap for what we're going to talk about today. I'm going to take a step back and give you a little bit of background on South Asians and cardiovascular disease risk in the U.S., as that's a major focus of this project that a few projects I'm going to talk about today. And then I'll give a brief description of the growth of our community and academic partnership, and also just my personal story about how I got involved in this work. And then I will present on a recently completed randomized controlled trial. I'll talk about that study design and some of the results from that study, which was the title of the talk, the Community Health Worker-Led Intervention, and then just some brief thoughts and next steps for our team's work. Okay, so just to make sure we're all on the same page, I wanted to first start with a broad definition of the population that I work with and focus on for a lot of my research work and my clinical work. So the South Asian community in the US is very heterogeneous and come from many countries. And so we use South Asians quite broadly. So this describes people with ancestry from South Asia, which includes India, Pakistan, Bangladesh, Sri Lanka, the Maldives, Nepal, Bhutan. It's a very large area beyond just India. But also in the US, we often refer to Indo-Caribbeans as South Asians as well. And so we do have a substantial West Indian community here in the Georgia and Atlanta area as well. So these are folks who have ancestral roots to India, but usually come from the Caribbean countries. Typically, we think of Guyana, Trinidad, Barbados, but it's a really large area of Caribbean countries that also represent South Asian communities as well. And I'll just share some personal experience. So in my own practice, so as Ashley mentioned, I practice at the Emory Family Medicine Academic Center Clinic, which is where our residency program and a lot of our learners are, which is in Dunwoody. It's just kind of at the border of Dunwoody, Chambly, Norcross, right off of just north of the city, not very, very close to Beaufort Highway. And I tell all of my trainees and students that I work with that sometimes they're going to fall into things because of personal characteristics that you have no control over, because there is a lot of evidence to basically support that, demographic concordance can matter in the type of care that we provide as primary care clinicians. And so when I found myself in this interesting situation after about a year or two of practicing in that area, was that 25% of my patient population was South Asian. And the majority of those patients were from Bangladesh. And I'll share a little bit about why that is. And I was diagnosing pre-diabetes and diabetes in 30-year-olds, 35-year-olds. And I was really taken aback. I am of South Asian origin, but I had no idea that this was such a big problem, that this was such a disparity in the South Asian community. Why is the prevalence of diabetes or pre-diabetes or other cardiometabolic health conditions so widespread in the community? And so like any good clinician researcher, I went to the literature because this was not a community, in fact, that I was very familiar with from a scientific research standpoint. And some of the earliest studies I found were actually the best data we have on Indian and South Asian diaspora come from the UK. Because one issue we often have is that we don't have good disaggregated data on Asian populations. But this little slide that I stole from this study by Unwin, which is from 1999, looked at a comparison of the most predominant ethnic groups in the UK and the prevalence of diagnosed diabetes by ethnicity. And what you'll see, this is the red line is men, the blue bar is women. And you'll see that compared to the general population of kind of UK citizens of European ancestry, you see these disparities in other ethnic groups. And then the largest bars are in the Pakistani and Bangladeshi communities, in addition to the Indian communities. But really, it's the Bangladeshi community that stands out as having the largest prevalence of diagnosed diabetes in the UK, which I was not aware of. And then people often wonder, well, why is that? The South Asians, like, what is it about South Asians that might put you at higher risk of these cardiometabolic health conditions like diabetes? And what we find is that in spite of lower BMIs, South Asians have a very unique phenotype that puts them at high risk for diabetes and other cardiometabolic conditions. And this is thought to be a myriad of factors that kind of play together to give South Asians this unique risk. Generally they are thin, but the way they carry fat puts them at higher risk. They tend to carry fat in the abdominal area, specifically visceral and hepatic fat, which in theory increases their risk of insulin resistance, but also insulin secretion deficiency. They have higher inflammatory markers, and then they have characteristic sort of patterns of their cholesterol that put them at higher risk of cardiovascular disease, which is low HDL, which is like that low good cholesterol, higher bad cholesterol, and higher triglycerides. And all of those factors together seem to really increase the risk of developing type 2 diabetes and coronary artery disease. Really, I think, we're hopefully in the next, we have some great data coming out of India and even in the US that hopefully will get to some of these underlying mechanisms of why this is, but this is kind of the phenotype that we often see in South Asian communities, which I was not aware of. And then when we look, this is very unique to South Asians. When we look at other Asian populations from neighboring countries to South Asian countries, we see that these patterns are really different. So this is data that's now dated, it's 10 years old, but I think it's still relevant and still about the same of the community health survey that's done in New York, which has a very diverse population. And what you see there is when they looked at cardiovascular disease and diabetes risk factors, comparing the two largest Asian groups, which would be South Asians, predominantly Asian Indians, and Chinese. When you look across these risk factors, overweight, obesity, diabetes, and hypertension, you see that the South Asians have increased risk compared to this other Asian group in all of these categories. So what about here locally in Georgia and in Atlanta, which is the community that I really have gotten to know and work with a lot. So here in Georgia and Atlanta specifically, South Asians represent one of the largest and fastest growing immigrant groups. Specifically, the Bangladeshi group is a unique group. So their patterns of immigration to the US are very different than other Asian populations. This is a group that is relatively new. In the last 25 years, the Bangladeshi community has grown substantially, and this is due to the mainly due to the lottery diversity visa program in the early 2000s, which is very different than other Asian populations, which may have immigrated under other circumstances. The most common was after the 1965 Civil Rights Act, there was an immigration act that opened immigration from other countries for immigrants from other countries who had professional degrees in STEM fields. So that was a time when it was very easy for a lot of South Asians to come to the US if they were pursuing higher education or already had degrees in other science and technology related fields. This community came under this lottery diversity program that didn't have that requirement. So what you see is this is a community that generally has less than a college education. They have limited English proficiency, and they are more of a blue collar community. These are the folks that are bagging groceries. They're working in grocery stores, convenience stores, gas stations. They're working in all the restaurants in the community. And so as we all know, a lot of these social determinants of health can really increase that risk. So that's something that we also think about in the community. I'll also just make one last comment about why this census is so important. So if you look at the Atlanta Metropolitan Census data on the size of the Bangladeshi community, they will say that that data shows that there's about 5,000 Bangladeshi immigrants or Bangladeshi Americans in this area. Our work with our community partners and the Georgia Bangladeshi Cultural Association says that this is off by about tenfold. The size of the community is around 50,000. So all the more reason to fill out your census and maybe question the data if it doesn't make sense to you. So this is a little bit about the community. And then I just wanted to share a few pictures that I thought were really great. I think most of you guys are local to the Atlanta area or around Atlanta metro area, but there was this really lovely article during the pandemic that the New York Times Magazine did about Atlanta and small businesses and how they were managing during the pandemic. And it highlighted a lot of the communities on Buford Highway. So you guys might be familiar. This is a typical picture scene from Buford Highway. And this is a typical strip mall that you might see in that community, which I love, which I think is a great example of the diversity and flavor that we have here in Atlanta. So I think you might be able to see there's like a Bangladeshi restaurant called Monsoon Masala. It's next to like a empanada restaurant, which is next to an Asian massage studio. So that's just like a perfect example of the milieu that you might find in that community. And this is actually one of the relatives of one of our community partners. He owns one of the local restaurants and he was featured in the article. I'll take a step back now. So as I mentioned before, I was talking about like how I'm looking at this data and seeing like what's happening here. I understand there's this higher risk, but how do we work with this community to develop community partnered solutions? How can I better understand what the needs of the specific community here in Atlanta are? And so that actually led to one of the first grants I ever wrote on faculty here at Emory. I actually wrote it with a couple of patients. And we got some seed funding from Picori to basically start a community advisory board, which the idea was hopefully to get some community input to help develop research. Literally, the goal was, let's develop some research questions of interest. What might the community want to focus on? And so it took us about a year to get the right players at the table. As many of you might know, this work is sometimes trying to partner with communities. It's time intensive. We have to put in the time. And so over the course of a year, this was like 2015 to 2016, we started working with different community partners in this community. And what I have to tell you, the thing that really helped, what really helped us kind of break away and kind of get the right players at the table, I don't think that's the right word, but like the right leaders at the table, was that we got buy-in from some of the religious leaders. This is a predominantly Muslim community, and we had two of the local imams, one from Masjid Omar, which is in Lilburn, and one from these two mosques are affiliated, the 14th Street Mosque, and getting their sort of buy-in really helped to bring other community leaders to the table. So we had representation from these religious organizations, cultural organizations, patients and family members with lived experience with diabetes that were on our community advisory board. And so our community advisory board is called ASHA, the Atlanta South Asian Health Alliance. One of our community partners came up with our lovely logo that you see here. And ASHA means hope in most South Asian languages. And so one of our community partners helped us come up with this logo. And so when we talked and we had these early conversations about what are the needs, why do you think that it's so hard for patients to manage their diabetes or prevent diabetes? What do you think are the barriers? And the community really came up with this list of about 5 things that they thought really were the problem. They said there's just a lack of knowledge about diabetes in the community. They also said they need help with translation. It's a very limited English proficiency community, as I mentioned. And they said that was often a barrier. They said anything that doesn't involve family isn't going to work. We need to involve family because this is a family-driven problem that needs a family-driven solution. They also said they need help with their diets. There's too many refined carbohydrates in the diets. And they also identified cost and insurance as a barrier. So as you all know, we live in a state that hasn't expanded Medicaid. This is a population that often ends up with fragmented care because they might have coverage one year and then they lose coverage another year. And so we see a lot of kind of fragmented bouncing between systems sort of care. So how do we take these ideas and issues that the CAB, our Community Advisory Board, brought up and kind of turn it into research questions and projects? We actually did a lot of capacity building as a starting point. So we started by saying, okay, let's see what's been done before. Let's do some literature reviews as a group. And we brought in speakers who had experience with implementation science, with diabetes interventions, just general diabetes epidemiology, so they could understand a little bit about what we know about diabetes. And let's use that information to develop a research question and then figure out how to plan and implement that. And so as part of our literature review, we ended up reading about a lot of work done by a team in New York City. There's a whole center for it's a Center for the Study of Asian American Health. There is a researcher there, Nadia Islam, who had done a lot of work in the Bangladeshi community. And our CAB really gravitated towards that team's work. They were using a model of lay health educators. They were doing a lot of cultural tailoring. They were providing meal plans that were tailored for the South Asian diet. And they were like, this sort of thing might work for us too. So another plug for just don't ever hesitate to cold email people. So I just reached out to Dr. Islam and I said, what do you think? Could we borrow your materials? Let's just say, can we borrow some of your evidence-based materials that you've already created and shown are effective in this community and see if we can use them here locally in Atlanta? And she was so responsive and has become such a great mentor to me and our team in terms of doing this work. But amazingly, it led to this beautiful cross CTSA collaboration between New York and Atlanta and Georgia. And we had the opportunity to get a lot of work funded to collaborate together and scale out some of the work that they were doing in New York and figure out how to tailor and implement it in Atlanta. And so, as I mentioned, our team and our CAB really gravitated towards this work that was being done, and they were using a community health worker model. And so, for those of you that might not be familiar with community health workers, these are usually frontline public health professionals that understand or have deep ties to the communities they serve, and often serve as a bridge between the community and health systems when there are barriers to accessing care that they need. They're used in lots of different capacities. They can provide culturally tailored in-language health education, health promotion strategies, work as navigators, linkages to social services. They can enhance and promote self-efficacy. And so they can play lots of different roles. And so we teamed up with this group at NYU to say, let's try and bring this work that's been done in New York and scale it out to the community here in Atlanta. So through that collaboration, we were able to get the DREAM Atlanta study funded, which is Diabetes Research, Education, and Action for Minorities. This was basically a culturally tailored community health worker intervention that was adapted from New York City to test the effectiveness of an in-language type 2 diabetes and hypertension management program for South Asians living in Atlanta. And we used a randomized controlled trial design to compare that to standard of care. So the intervention was very similar to what has been done previously in New York, just tailored for this population a little bit, and I'm happy to talk about that in a little bit more detail. So this was an intervention in which those in the intervention group received 5 group sessions over 6 months with 2 one-on-one health coaching sessions to goal set for each individual participant over the course of that 6 months. And the study population of interest was South Asian adults with type 2 diabetes and uncontrolled hypertension, which we defined as a blood pressure of greater than 130/80 using AHA standards. And the study period ran from September 2019 to June 2021. So you can probably tell from the study period that some things happened that we didn't anticipate. So COVID hit. And so we had to quickly make a lot of COVID-19 related modifications. So what we had to do was first we had to move from in-person to Zoom, which was, you can imagine, a challenge, which I will talk about a little bit. And then we also had to move from clinic to community-based recruitment. Our initial plan was that 3 of our community health workers were going to be embedded in different clinics, one at our Emory clinic, another at Grady Brookhaven, and another at the Shah clinic, which is in Duluth. But because of COVID-related restrictions, we couldn't do that. And then all of our planned data collection had to be moved to remote data collection. So we were using a combination of like FaceTime and Zoom to collect survey data, and also home blood pressure and glucose monitoring. So we were like dropping off blood pressure cuffs on people's doorstep and then running away to make sure they had all the equipment they needed for the data collection. So this is just an example of our CHW team showing participants how to engage or how to do their blood pressure checks remotely. And so those are just pictures of our 3 community health workers and our, at the time, our research coordinator, Christina, is on the call as well. And so you can imagine we had a lot of digital challenges. So this community, as I mentioned, had a lot of reasons to maybe fall through the digital divide, right? They are limited English proficiency. They're patients with diabetes and hypertension. So on average, they were over 55. And so they're a little bit older, and they have limited English proficiency. So these are 2 risk factors for really having trouble sometimes with connecting remotely. And so some of the ways that our community health workers helped each of these patients or participants overcome this, I'll just give a few examples here. And even our community health workers, I have to mention, had to learn how to do this. They had to learn how to send out Zoom invitations. They had to learn how to project their slides remotely. We all know how challenging that can be at times, right? And so we had to address each of these barriers, even for our community health workers. So for example, our community health workers had limited experience with the software. So this is where Christina, our research coordinator, was instrumental. She would sit with each of the community health workers and practice with them for hours to make sure they felt totally comfortable, because empowering our community health workers, we knew, is the key to them being able to empower other people. Our participants often didn't know how to download applications onto a smartphone. This is where our community health workers got super creative. I'll just share one example. One of our community health workers, Sakila, she was trying to get a patient, one of her participants, to connect on Zoom. And she asked, is anybody at home? And the participant said, my 5-year-old grandson is at home. And she said, get him on the phone. And she got the 5-year-old grandson to go to the app store, get the Zoom app, and get this grandfather connected. And so we really utilized every possible resource. We were utilizing family members, our team, any way to get them connected. We had a lot of challenges, I think, for those of us that on the research side, just like the documentation and how to get it all into one system. We were able to work with our IRB because there was a lot of flexibility during that time to use just photos rather than scans for our IRB consent forms, which was huge to try and get the written consents taken care of, because this was a time when it was really hard to do the e-consents, which I think has gotten a lot easier now. Some of our participants didn't even have an email address. So our CHWs were actually helping community health, helping the participants get their first email address so they could actually get study documents. And then participants who didn't know how to log onto Zoom, as I shared, we're really utilizing family members. And then lastly, internet connectivity challenges. So one thing that we did that really helped, because it was all Zoom, is we tried to offer the sessions at multiple times when another family member might be home. So oftentimes we would use, maybe it wouldn't be the participant's tablet or smartphone, but they had a family member who had a smartphone. And so we would wait till the end of the day after everyone's finished with work or school, or virtual school, and then do a session then, or do it on the weekend. So we offered multiple times at different times of the day to try and get around some of these internet connectivity issues as well. And some of these findings we published in a paper that's cited there in the bottom as well. So we went through a lot of kind of struggles to get here, but then we were finally able to do the study. This is just our consort flow diagram, which is very small and wordy, but I just wanted to just put it up here just so you can see a little bit about our study design. So essentially we used a few different modes of recruitment. We still did some clinic-based recruitment through EHR data polls. And then we used community recruitment and other primary care provider referrals. And then we did like a phone screening to verify eligibility for the study. So we ended up consenting 195 participants to the intervention. Every participant received the first session, which was a general overview of diabetes. And we had 193 that did our first session. And then of those, we were randomized 190 to either proceed with the intervention or stay in a kind of a usual care control group. And you'll see that I just want to highlight that we had very high retention. So in the treatment group, we had 97 that were randomized to the treatment group, and 92 completed the study. And even in our control group, we had 93 that were in the control group and 91 where we were able to get endpoint survey data collection. So we had over 95% retention for the entire study. And this is just to show randomization worked on average. We had a little bit more women in the study. It was like 55, 56%. And the mean age, as I mentioned, was a little over 55. Again, as I mentioned, our primary outcome was actually blood pressure control, because as you know, diabetes and comorbid hypertension are very common. In fact, some of our EHR data polls basically showed in New York and Atlanta that 75% of South Asians with diabetes also had comorbid hypertension. So our primary outcome interest was blood pressure control, but also feasibility, as this was still a pilot study. So we were measuring this by our recruitment, enrollment, retention, and satisfaction with the intervention. Secondary outcomes included weight and BMI changes, as well as A1C changes. So I'll just orient you to this first slide, and then every other slide is going to follow a similar scale, okay? And so I'm just going to present some of our quantitative, like our biometric outcomes first. And so you'll see, I don't know if you can see my little arrow or not, but so the treatment group is over here on the left side of the screen, and then the control group is over here on the right side of the screen. The blue bar represents their baseline measures, and the orange bar represents the follow-up after 6 months. And all of these were significant differences between these two groups. So at baseline, the systolic blood pressures was on average about the same, 139. And you'll see that in our treatment group, we had about a 12-point drop in that blood pressure, systolic blood pressure, compared to a smaller drop in the control group. Similar changes in diastolic blood pressure as well. So we saw a significant drop in diastolic blood pressure in our treatment group. And then our outcome of interest was really how many ended up with controlled blood pressure by the end of the intervention. And you'll see that only 6% had controlled blood pressure at the beginning, and almost 40% had control of their blood pressure by the end of the study. It was a significant difference from our control group, even though they also saw a small increase in their controlled blood pressure as well. Although I mentioned that in general, BMI is maybe not the best marker because South Asians get cardiometabolic disease at low weights, we did still see a significant change in weight in the treatment group. And we also saw changes in A1C. The A1C dropped by about 0.5 in the treatment group, whereas there was this was not a significant difference in the control group. So you can see that we had some really successful sort of quantitative outcomes in our small pilot study. And so, one of the things we did is we went back and we talked to a lot of our staff and our community health worker team about what they think led to some of the success of a program like this. Our community health worker team said that Zoom was actually an advantage. And so the reason they said that is Zoom overcame the biggest barrier to doing anything in Atlanta, which is traffic. And so the ability of having Zoom and not having to have people gather in one place was actually an advantage to the study. This allowed them to also be much more flexible. They could offer the sessions at multiple times. They could, work with participants depending on their individual schedules. Now, that being said, our group sessions were really well attended. I don't know if you were able to see, but like on that one picture I showed about the blood pressure education, there was there were 35 participants on that session. And generally the sessions were very well attended. They were usually able to get at least 25 to 30 participants in the Zoom sessions. This sort of format actually also led to they felt like it led to community and social connection in a time when people were feeling quite isolated, which we did not think about or anticipate, but that's just how it happened. And they said because of the pandemic, people were at home more. And that also, they think, led to people just being more engaged with the program. The other really lucky thing that happened to us is we launched this study immediately after this community had their first virtual Ramadan. So we were able to kind of capitalize on the fact that a lot of people were able, had already had a little bit of experience connecting on video conferencing platforms because of the virtual Ramadan during 2020. And, lastly, I think our community health workers would tell you that they felt like they were addressing this unmet need, that people are feeling isolated and lonely, and these women could be there for them. And it was something that they hadn't anticipated, but felt like they were really able to address through this sort of telehealth program. So any great study that has some strengths but also have some limitations. So there obviously are some limitations to the generalizability of what we found here, given our Atlanta context and the implementation of just this during the pandemic. We were only powered to really look at the change in blood pressure control. So we would need larger trials to look at some of the other clinical outcomes of interest. We had limited ability to collect in-person data, so we did use a little bit more self-report. So we used survey data, and for the clinical measures, we asked patients to try and give us data from like their patient portal, if possible. And the blood pressures, we gave each, it was standardized in the sense that everyone got the same blood pressure cuff, but we were not checking it ourselves. We were doing that via FaceTime or Zoom. But conclusions are that like, and in language, which I think I'm really preaching to the choir here, but that a culturally tailored in language community health worker led diabetes and hypertension program is feasible, it's acceptable, and it can be effective to improve blood pressure control in at-risk South Asians. Telehealth is also feasible, but we need further evaluation to really understand barriers and facilitators to telehealth utilization in the community. And this study hopefully would have broader implications to other at-risk immigrant populations as well. A lot of our findings are already published. So these are just 2 papers, other papers on these with a little bit more detail if anyone's interested. And next steps for us is that this pilot data has helped us kind of realize that this particular community, we realized that like place didn't matter as much as we thought, and the culture and language connection was quite important. One thing we found was that people were joining the Zoom calls from anywhere. We had people during the intervention that traveled back to India or Bangladesh and still logged on. So that gave us some really nice preliminary data to write an R01 with our NYU colleagues to create Dream National. So Dream National is funded by the NIMHD as well, which funded this pilot study as well, to scale this intervention nationally. So we are planning to scale and test the efficacy of a telehealth intervention for the same study population, but this one will have a much more robust implementation evaluation that we were just unable to do because of our time constraints. This map is showing some of our different clinical community partners, but we're really recruiting quite broadly, but we have partnerships kind of across the Southeast, but also in the Northeast as well for patient recruitment. And this is a fully telehealth intervention that will incorporate Bluetooth-enabled remote blood pressure monitoring for hopefully a more objective measure of blood pressure. And as I mentioned, I didn't do this work alone. I have a whole team of folks that I'd like to recognize and acknowledge for their help with the projects, and our funders as well, which have been the NIMHD, the Georgia CTSA, and the New York CTSI as well. Okay, and that's it. That's all I got.
That was wonderful, Dr. Shah. Thank you so much. So
Yeah.
I have I took a lot of notes. So I have a lot of questions, but I would also like to open the floor up to those of us who are in attendance. Yes, Michael Erickson has his hand raised. Go ahead, Michael. Oh, I might have to allow you to talk, Michael. 1 second. Okay, go ahead now.
Thank you. And thank you, Megha. What you're doing is very interesting and overlaps a lot with our work and also our collaborators that we have in that. Nadia Islam is one of the leads at the NYU Prevention Research Center.
That's right, yeah.
And so we know each other through that effort. And then some of your Emory colleagues, Venkat and others are colleagues as well. So there's a lot of connections, and we're also using community health workers and also doing some diabetes work. So this is a great opportunity to learn what you're doing and also to see about future collaborations in our PRC with a refugee community in Clarkston. So thank you for agreeing to do this, Ashley. Thank you for finding her to do it. And I guess the question I have is, can you say more about the intervention itself?
Sure.
I know that it's delivered by community health workers, and it was delivered virtually through Zoom, but the number of sessions, what the content was, and just give us an overview on the intervention would be helpful.
Yeah, absolutely. So The intervention itself was 5 group sessions that covered evidence-based topics related to diabetes and hypertension management. So it was an overview of diabetes and hypertension. It was stress management. It was physical activity. It was diet and medication adherence for the 5 topics that were covered, that were all basically culturally tailored in language for this community. Most of the material had already been tested in New York City. The only new content that we added was very specific to blood pressure management, which was a new component for the Atlanta pilot study that had not been done previously in New York. And so all the rest of the content had previously been tested in a similar population in New York and found to be effective. And then in addition to the 5 sessions, the group sessions, there was 2 one-on-one health coach sessions with the community health worker that were kind of grounded in motivational interviewing to kind of set individualized goals for each of our participants. So that really varied by the participant. And so each of our community health workers had already received, like prior to starting the intervention, they did community health worker certification and then some specific continuing education around diabetes and hypertension, and then worked with our behavioral psychologist in our department to kind of develop motivational interviewing skills as well. Yeah, and so those are the main components of the intervention. And then we had kind of 2 major data collection periods, which was at the beginning, at this study start, and also at the end point. But then there was 2 smaller data collections during each of those individual coach sessions with the community health worker. That was a little bit smaller, little survey about how they felt about the study or the intervention thus far.
And so for the control group, besides the initial virtual session, what did you do, if anything, for the control group?
Yeah, that's a great question, and I did not actually include that slide. Sorry. So for the control group, they each got that first group session, and then we did the same data collection at baseline and endpoint. But then at the end of study, we offered a wait list education. Like, so for anyone who was in the control group, they also got the intervention, which was much more acceptable to the community, that everyone would get the education, like the sessions. It was interesting because Dr. Islam and her team, when they'd done this work previously, she was like, we get very few people that want to do the sessions after the study ends. But we actually had about 60% of the control group participants that wanted to do the sessions after the study period. But so we didn't actually collect any data on change in that group, though, but we just offered it as kind of a nod to the appropriateness of kind of addressing the community's needs.
Great, thank you.
Mm-hmm.
Yeah, it's interesting, Megha, that you saw decreases on almost all of your outcomes in the control group too. And I don't know whether those were statistically significant, but I could see from the tables, the charts, that kind of everybody went down. So do you have a sense about why you saw those decreases in the control group too?
Yeah, well, not all of them, you're right. Not all of them were significant changes from baseline to endpoint in the control group. But it's a well-connected community. So we anticipated that there would be some spillover effects, because everybody kind of knows everybody. And so we did kind of consider that was a possibility, that there might be some spillover effects. So you're seeing some change in that group as well.
Maria, it looks like you have your hand up. Go ahead.
Hi, my name is Maria, and I'm an Atlanta native. My family's from Pakistan, and growing up, I've always had a lot of Bengali friends.
Mm-hmm.
So, first of all, I'm really happy that your target group was Southeast Asians, because I feel like they're a little underrepresented in public health research and interventions. So thank you for that. I was wondering, Was there any opposition on from the participants' side regarding your intervention? Because I know that like for example, we're how should I say this? Like, did people let traditions and traditional norms and cultural values get in the way of participating in this intervention from what you've observed?
That's a great question, Maria, and thanks for that kind of background about your personal experience as well. I'll just comment, you're absolutely right that we are Asians in general are underrepresented. We represent 7% of the US population, and less than 2% of federal funding goes to study Asian populations. So all the more reason that we need to increase the pipeline of researchers in this area. And so your question about cultural norms. So, you know, our experience, and I am curious, I would love to hear about your personal experience, is that diabetes and cardiometabolic disease are so ubiquitous in this community. Everybody knows somebody. Everybody has a relative with diabetes or knows somebody affected by diabetes. So it's pretty openly talked about. And so we didn't really have to worry so much that people didn't want to be in group sessions with other, like to share their health around diabetes and hypertension specifically. But I will say, taking a step back, when I first started doing this work, where I just was trying to like talk to people in the community, I started very broadly. It wasn't really my intention to just focus on Bangladeshi communities. But what happened, I remember in that first year that we had that small PCORI grant to develop a community advisory board, we did these events at our clinic that we called Chai and Chat, where we tried to invite community members to come and just share their experience or talk about how chronic disease affected them personally or their community. And I'll never forget that we had this one session. We had about 7 or 8 people attend. I think the majority were Muslim, and there was one person who was not Muslim. I think that person was Hindu. And it's very hard to talk about, I think in any community, but especially in the South Asian community, it's very hard to talk about health and lifestyle without your culture and religion and spiritual beliefs coming up. And, you know, we started having this conversation about overeating, I think it was, and somebody was quoting something in the Quran about how the way you're supposed to eat, the Quran even tells us that you're supposed to eat and it's like 1/3, 1/3, 1/3, I think, and like 1/3 should be empty or air. And the person in the room who was Hindu just kind of shut down. I could just see it on this person's face that they were just like, you know, shut down. And then that person got up and kind of left the room, and we went out and talked to her, and she was like, "You didn't tell me this was going to be about religion. That's not what I came to talk about. I came to talk about diabetes." And we realized that like there's just too much heterogeneity in this community to lump all South Asians together. And so that's when we initially, with our community partnerships and kind of community outreach, we decided to focus on the Bangladeshi, like the Muslim community, because again, as I mentioned, that was a majority of patients that I was also seeing in clinic. And so we had some good community ties already to people in the community there. So I don't know if that's a broader sort of comment about your question.
Thanks, Megha. Yes, Renati, me, your permission to talk. Okay, go ahead.
Thank you for this amazing session, Dr. Megha. My name is Unnati. I work as a health educator in the State Refugee Health Program. And just following back on the previously asked question about the habit of probably overeating in the community, I have come across people who have raised concerns on the kind of diet that most of the such diet programs or nutritionists would offer is not vegetarian, which is I mean, I come from a Hindu family, so I think from my conversation with people, they are not very open to experimenting or just restricting, which causes overeating. Is that something that you experienced when you were working with them?
Yeah, so certainly we had to do a lot of tailoring, cultural tailoring of the dietary advice that we were offering. So we really tried to for example, we created, with our NYU colleagues, we created South Asian my plates that were very specific to the Bengali diet, So Bengalis eat a lot of, for example, a major protein source is seafood. And so we had, preparations of a plate that basically showed how to, that your meat and your other protein should be a quarter, your vegetable, your subsies should be half, and then your carbohydrate should be another quarter. And we took, our CHWs were taking pictures of their own plates that they were preparing to share with the participants. What we found is rather than try and provide general advice, which I think you probably have seen in your own experience, is that tailoring it as much as possible was really important. So even, for example, with physical activity, we cannot tell a South Asian Bangladeshi mother whose primary job is to stay home with her family, who's a housewife perhaps, to then just start going to a co-ed gym. She's not going to do that, right? So we had to figure out well, how can we develop a physical activity program that's meant to be done in the home for someone who does activities in their home? And so we were showing how, even when you're doing your regular domestic activities, like sweeping the floor, putting away dishes, how can you get that heart rate up a little bit more while you're doing those activities? Our community health workers created short, YouTube video exercise programs in language that they could easily do at home with things they have around the house, like water bottles or cans in their hands, for example. And so we certainly found, and then the other aspect was really incorporating the culture around, if people are overeating, what does our culture tell us about how much we should be eating? And so our CHW team was very good because they had this own background of incorporating that into the sessions.
Thank you. I have I have a lot of questions, but one I wanted to ask you in maybe our last couple of minutes.
Sure.
You mentioned, how strong your online attendance was. And because it was during the pandemic, it sounds like one hypothesis was because people really needed an opportunity for connecting with other people. And that was what we had at the time. And I'm just reflecting on some of my own experience now, after years of that, there's so much kind of Zoom fatigue, right? And I wonder if you could comment on whether you feel like online attendance will continue to be as strong now when we don't kind of need that connection, whether it's in person or online, as much anymore.
Yeah, that is something that we have certainly talked about as a team. And that's, kind of part of what we want to test in this new R01 is the sustainability of telehealth after the pandemic. I will tell you that in other pilot studies that we just wrapped up another pilot study where we were looking at spillover effects among household members of a similar intervention. We were still, it was a much smaller study. It was only about 60 patients that were in that study. But the online attendance was still very good. But part of that is these women, the community health workers. They are persistent and they will not give up. And they call our participants over and over. They will offer the sessions one-on-one if they don't want to do the group session, for example. Generally though, in this study, we didn't have anybody that didn't want to do the group sessions. They loved the group sessions. The materials were meant to be about 50 minutes of kind of content, and then about 10 to 15 minutes for questions at the end. And these sessions were lasting on average about 2 hours, is what the community health workers told us, because people were just enjoying the chance to talk. but we'll see. I honestly, that's kind of what we want to see with this new grant. It literally just got funded. So we are just reworking all the materials now, and we start recruitment this summer. And so that is certainly one thing we want to evaluate is the sustainability of this sort of model. But that's certainly a possibility. We all have some.
Well, I
sense
hope you'll come back and share what you're learning with the R01. It sounds like you have obviously really strong pilot data to inform that work. And I'm sure you're going to learn a lot. So we hope you'll come back and share what you're learning and help us maybe think about, you know, what we might be able to adapt from some of what you're doing with some of our communities in and around Clarkston. So I think there's definitely a lot of room for partnership. And for others on the call, you know, Dr. Shah's information is up on the screen. So, you know, feel free, I think, to reach out to her and or me. Just want to thank you so much, Dr. Shah, for your time today. It was such a fascinating talk, and you're doing such important work, and we're happy to have heard about it today. So thank you.
Oh, well, thank you so much for the opportunity. And I think it's Michael, I think mentioned like, yeah, I think there's so much potential for overlaps. I'd love to keep in touch. And if there's opportunities for us to work together, you know, I'd love to keep in touch. So please don't hesitate to reach out to me. My email address is on the slide there. So
Absolutely, for sure.
Okay.
And then just, you know, lastly, everybody, you know, please bookmark this next talk for our April webinar. We have Professor Hodel Tantakar from University of Massachusetts at Amherst. She's going to be talking about some of her work related to mental health. So reducing stress, anxiety, and depressive symptoms in a family-centered preventative intervention for immigrants is a feasibility trial that's funded by NIH. So please join us for that. And if for some reason you do not have the information that you need to do so, feel free to shoot me an email. I'll make sure you're added to the registration list or invite list. And please, you know, always feel free to go to our PRC website listed there. We have all of our webinar talks posted for you to peruse at your leisure. So thank you again, Dr. Shah, for your time today. Have a great rest of your week, everybody. Bye-bye.